last session, kind of complex TAVR procedures in mainly valve. I'm very happy to have a co-moderator with Myeong-Ki, Hwang, and distinguished panelists, Dr. An, Buddhari, Dr. Hwang, Dr. Kang, Sook, Dr. Lee, Dr. Shirai, Dr. Tada, Dr. Yamamoto, come on here. Come on the stage, please.
Okay, let's start the live cases. Case number 6. Dr. Bach, DW Bach, are you ready?
Can you hear me?
Okay, please start.
Okay. I'm DW Park, and this session is a valve session. I'm gonna introduce our team and Jinho Lee, and he's now the professor in the Kyunghee National University and graduated our fellowship, and also the Seung-Jung Lee, our senior fellow. Okay, can you introduce patient background?
Thank you, Professor Park. I will introduce this case. We have a 85 years old female, and she was admitted for dyspnea insertion via functional class 2, and she underwent surgical aortic valve replacement 14 years ago, C 90 millimeters. He had a diabetes and hypertension, and her BMI was 26, and STS score was 8.7%. Euro score was 9.4%. ACD shows sinus rhythm, and chest X-ray showed borderline cardiomegaly. Echocardiography showed flow acceleration at the IV, and then motion limitation of the aortic valve leaflet. And the aortic valve area was 0.5 centimeter square. LVEF was 75%, and mean pressure gradient was 61 millimeter mercury. And maximum velocity across the aortic valve was 5.2 meter per second. And then the inner shoulder diameter was 60 millimeter, and long diameter was 80 millimeters. And the inner area was 223, and the inner perimeter was 15.3 millimeter. And the sinus of SAVR's diameter was about 24 to 26, and ST junction mean diameter was 27. And elevated to annulus area ratio was 1.7. And then the coronary height of left coronary artery was 6.2 millimeter, and that of the right side is 6.6 millimeters. Yeah. This is additional analysis for coronary obstruction risk. The valve to left coronary artery distance was 2.4 millimeter, and then the valve to right coronary distance was 2.8 millimeters. The valve to ST junction, that distance was from 1.6 millimeters to 2.4 millimeters. And both sides of the iliofemoral arteries are feasible for the transfemoral TAVR. And the recommendation of the level of the valve was just below 3 or 4 millimeters of the previous surgical valves. And this is the sizing chart for evolutive effects. And this is annulus projections. And this is our plan.
Okay, so and this is upper part as shown like this, and very complex. So and this is 14 years and the valve, and which surgical valve was used for this patient?
CE valve.
Yeah, CE valve, and already durability is gone, and 14 years ago, and age is very high, 86-year-old, and this patient is one of a very complex in the valve case. So, and as you can see, could you show the CT scan? At the planning of the valve procedure and the TAVR and the TAVR, and we have available web, and CT planning is so important, and we measure the ID and the character of the surgical valve. Also, in the valve-in-valve procedure, one of the critical point in the exact assessment of coronary risk plane. The next one. So the aortic valve complex and this is show the size of the Valsalva and the size of ST junction. And next one. Next one. So, and the coronary height is very narrow, and we know well that less than 10 millimeter is a very high risk, and the left coronary system and the 6.2, and there was a sort of the higher risk of left coronary, and the RCA was also 6.6, and the two both coronary artery less than 10, 6.2 and 6.6, and next one. Also, VTC is one of some space, occupying space, the sinus of the Valsalva area, and the VTC is also very narrow, and practically more than 4 is safe, and less than 2 is a very high, most high risk, and the 2 from the 2 to 4 is a relatively high risk. This VTC is a 2.4, 2.8 is absolutely, and the coronary height is low. And the coronary VTC, VTA area is very narrow, and that patient is a very high risk of the patient. Also, next one, the sizing matter, and this is also the initially put the very small the size and the C valve, and so not suitable for the SAPIEN valve. And the next one, sizing chart, and even though we are planned to the SAPIEN 20, there was a more than. The sizing doesn't matter. It's only available option is Evolut system. If you plan to 23 and the perimeter oversize is 35%, and we cannot consider any other option. SAPIEN is not available. Also, Nabito system is intra-annular valve type, and for such case, we just only consider supra-annular valve type. Also, we are very careful for coronary obstruction risk. So. And I'd like hear opinion from the moderator and the panel. How would you treat this high risk valve-in-valve patient?
As a TW comment, this is the real high risk of patient. Is that we have a lot of point to have discuss. Any comment from the panelists? This is the typical patient in the Asia, with the small size of woman and the deployed underwent the small size of the surgical valve, and the more than 10 years later, this is a kind of phenomenon is the common and the typical scenario about this kind of patient. Okay, go ahead.
Yeah, I would do the same, exactly the same thing, choosing supraannular self-expanding, protect both coronary. I'm wondering how do you put two catheter from one leg? Did you puncture two holes in one femoral?
Yes, it's a femoral as well as radial artery, and protect both coronary artery, right coronary artery, left coronary artery. As you can see, we puncture radial artery and another femoral, both femoral artery, and put the wire for the coronary protection.
Mm-hmm.
Will you do the predilation of this patient?
Yeah, right. It's wiring take more than 10 minutes. It's very difficult, and the Vmax is more than 5.2. It's very narrow. Also, and the pressure gradient, as shown in the hemodynamics, is very high pressure gradient, and the mean velocity more than 60, and very tight. Usually, such like 14 years ago, SAPIEN put the surgical valve, and the wire passage is so difficult. Usually, compared to native valve, surgical valve much sticky. Sometimes even caster is pigtail caster does not pass well. So absolutely, and the SAPIEN valve, we should do predilation 100%. It sometimes do not pass the failure the surgical valve. Also, even we consider Evolut system is very difficult sometimes to pass the wire. So we do the predilation using which balloon side we used? 18, and the inner diameter is 19. Inner diameter 17, okay.
Do you consider to use the cerebral protection devices for this patient?
We have no space for cerebral protection. As you can see, right coronary artery, left coronary artery protection. We also pigtail in the aorta and the LV. We don't have much the space for the central. And as you mentioned, the CP would be the helpful participation. Okay.
In my personal experience, especially in the valve degeneration, this is the 14 years, and the valve area is 0.5, very narrow.
Yes.
And then this kind of patient, and the debris of the cerebral protection is a huge size of it, not a particle. The characteristics of the debris is a calcium tissue. No, it's the degenerated tissue. Bulky of it is and then surprised that it is emboli to the brain. It almost be so. Personally, I think this kind of patient is absolute indication for to use a sentinel.
So,
And
this is
additionally, you do the predilation, and it means the one touch of it, the increase of the stroke is more and more and more.
Ready?
What size balloon?
Yeah, this is 18 GMED, and the passage is very difficult, and because of usually very sticky. Okay, everybody ready?
What size of balloon?
Facing on,
doctor?
18, facing on.
18.
Okay, inflate. Okay, and then, okay, deplete. Okay, facing off. Okay, 자, 이거 보면서 빼자. 자, 그래서 left guiding caster, I slightly pull back the left guiding caster. Okay. 자, 보면서 1, 2, 3, 1, 2, 3, 3, 3. This is 18 GMED balloon. Okay.
Could you show us the predilation angiogram?
Okay, absolutely. Okay, and the GMED, and could you show us the previous view? As you can see, this is 18, and the center part, we are predilation, and looking at the coronary, absolutely, slightly space in the coronary zone, and the valve-in-valve procedure. Anatomically, we consider three parts. One is NSP, neoscrotal plane, and also CRP and coronary risk plane, and also surrounding area is some space zone. Absolutely, if you put the envelope valve and the neoscrotal plane is over than the coronary risk plane, and only we much concerned about the space, and we never consider valve fracture. We will do valve fracture. Absolutely, coronary obstruction happens 100%, and we will do just put the envelope valve and then check the hemodynamics. Okay, envelope sheath back, inline sheath. Okay,
I agree with not to try the valve fracture.
Absolutely.
Patient age is 85.
Yes. Although some hemodynamic pressure gradient remained, that's okay. Yeah, this patient is, AES component is a major portion, Vmax more than 5.3, and the mean pressure gradient more than 60. Okay. And this is, we're gonna plan to the 3 o'clock.
Really small size alone.
Yeah.
What do you think?
Apex valve.
Valve fracture, no. Immediate after, even after. Or what it is.
이게 그거지? 이게 저기. 오케이. Hsin. 오케이, 들어갈게.
There are too much space between the device and the size itself, right?
Okay,
we
have great
generally like to
curvature.
use a self-expanding
we make
valve in
sure
here, but
좀 맞춰봐.
if the two corners are so low and
lateral
you
part.
need to put a stent in, it'll be not pretty
Okay.
hard. So whether you
And
actually
then
use a
이렇게
sapien in here too, there's another consideration. Then you can rescue
세시
both
방향으로
corners
하고.
pretty easily.
조금 더 앞으로 돌려볼게.
Let's see how it happens, to see whether this
반대다.
2 millimeters is enough of a space.
이렇게 됐다, 그지? 네. Okay. So we make sure it's great curvature. Hand mark was the lateral part, and then the pigtail over here, and the negotiation is so important. And then we push, and then put the pigtail over there, and then push. Okay. Cusp overlap view. And the landing position usually in the valve app and 비니바파 web in the position 3 and 5 millimeter below and zoom하고. Okay, here we absolutely have a landing mark. 이거 피그테일 여기 있지? 오케이, 이렇게 한번 살살 해볼게. 자, 준비됐지? 테스트 살짝만 해볼까? 오케이, 자, 여기서 오케이, 릴리스. 자, 120 페이싱. 자, 릴리스. 릴리스. 자, 오케이, 릴리스. 이게 커시브 오블랩 뷰. 릴리스. And 릴리스. 오케이, 릴리스. 오케이, 자, 릴리스. 자, 슬라이드 디프레이스. 오케이, 릴리스. 한 바퀴 쭉 돌리고 천천히 스탑이. 릴리스. 오케이, 릴리스. 혈압 떨어지면 얘기해 주세요. 릴리스. 오케이, 릴리스. 오케이, 릴리스. 오케이, 뭐 딥 인플레이션. 오케이, 저 반대로 좀 가볼까? 좀더 빼겠어. 오케이, 나 풀어봐. 잘 오를 때까지. 오케이, 자, 우리 페이싱 좀 해주세요. 아, 하고 있어? 아, 혈압 좀 올랐나? 오케이, 볼러스. 오케이, 절로 에리어로 한번 가봐. 자, 볼러스 한번 주세요. 너무 깊다, 그지? 다시 감자. 쭉 감아. 오케이, 오케이. 자, 우리 혈압 그 한번 주세요. 쭉 감아. 쭉 감아. 쭉 감아. 오케이. 쭉 감아. 네네. 쭉 감아봐. 혈압 나오지? 자, 어디 나오고 있어? 자, 오케이. 자, 좀 기다려. 자, 조금 페이싱 풀어봐. 아, 오케이. 오케이, 좋았어. 아, 됐지? 오케이, 됐다.
Takes time
이
to
뷰에서
recover the blood
커시
pressure.
뷰에서 맞춰봐. 이게 아니 커시 뷰에서 하지 말고 이 뷰가 낫겠어. 자, 네, 트라이 커시 뷰로.
천천히 하세요.
네. 오케이, 됐지?
너무 빨리 하지 말고
줌하고,
혈압 좀 리커버리 된 다음에.
줌하고, 잠깐만 혈압 좀 올라오면 혈압 조금만 올려주시겠어요? It's because of space is very narrow at the time of releasing is the device was deep dive. 조금만 혈압 올라오면 하자.
서두르지 말고 천천히 하면 돼.
오케이, 됐지? 자, 한 바퀴씩 돌려봐. 천천히 해볼게. 오케이, 됐지? 자, 릴리스. 우리 페이싱 120. 자, 릴리스. 오케이, 릴리스. 오케이, 릴리스. 오케이, 릴리스. 오케이, 릴리스. 오케이, 천천히. 자, 릴리스. 혈압 괜찮고. 릴리스. 오케이, 내가 할 때 릴리스. 오케이, 자, 릴리스. 오케이, 자, 릴리스. 자, 오케이, 릴리스. 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 혈압 쭉 올려봐. 자, 잠깐만 기다려보자. 자, 페이싱 꺼봐.
네, 페이싱 목표.
혈압 나옵니다. 좀 나오지? 잠깐만, 뷰를 여러 군데 확인해봐야 돼.
네.
자, 우리 다른 일단 커시브 오블랩 뷰도 한번 확인하고.
네.
자, 테스트. 그치? 자, 그 다음에 우리 그 뷰, 우리 그 3커스 뷰, 코플란을 보러 가봐. 이제 약간 낮아. 그치? 너무 샬로해, 그치? 자, 여기서 한 번만 찍어볼게.
I think it's too shallow, right?
Yeah, right. 오케이, 한번 찍어보자. 그치? 너무 샬로우. 한번 감아서 다시 하자. 오케이, 쭉 감아. 오케이. 천천히 쭉쭉 감아. 쭉쭉. 좋아요. 오케이. 자, 혈압 괜찮지? 자, 여기서 한번 천천히 좀 깊은 사이에서 해볼게.
페이싱.
자, 오케이. 페이싱 지금 아직 안 하고 있지?
네, 안 하고
자,
있어요.
오케이. 혈압 괜찮고. 자, 릴리스. 오케이, 릴리스. 오케이, 릴리스. 좀더 들어가서 잠깐 천천히. 릴리스. 오케이. 자, 릴리스. 한 바퀴 또 릴리스. 기다려. 120. 자, 릴리스.
천천히
120.
같이
천천히 기다려.
잡고.
Good.
오케이. 릴리스. 오케이. 기다려.
Just good.
릴리스. 오케이. 릴리스. 혈압 떨어지면 얘기해줘. 릴리스. 쭉 올려봐. 오케이. 오케이. 자, 됐어. 페이싱 끄고.
Okay, it's time to the check with the angiogram.
Absolutely. Yes.
This position is better than before. And
Yes, I think because of the very narrow space, if I try to the exact position, the valve device is much slip down and slip up. Okay, 여기서 한번 찍어보자. 자, 준비됐지? 자, 그자, it's good.
I think it's
Yeah.
perfect.
Okay.
I think
잘해요.
considering that the very high risk of patient and this is a third time the trial, it is good for
Yeah,
the release of the valve.
이게 커스
The
오블레트야.
result is 100% perfect. No, but it is acceptable.
자, 오케이, 그 이제 there is no AR. 오케이, 아까 코플라너 뷰 가보고 여기서 풀자. 이거는 더 맞추기가 천천히 가봐. 오케이, 됐지. 자, 릴리스,
천천히 더.
릴리스, 천천히 한 바퀴 돌리고. 오케이, 나 120 한번 해보고. 자, 릴리스, 천천히. 자, 릴리스. 자, 텐션 릴리프 할게. 자, 릴리스. 한 바퀴 또. 릴리스. 오케이. 자, 릴리스. 오케이. 릴리스. 오케이. 됐어. 릴리스. 오케이. 더 릴리스. 오케이. 릴리스. 더 릴리스. 오케이. 더 릴리스. 오케이. 페이싱 꺼도 되겠다. 릴리스. 오케이. 릴리스.
Body
오케이.
access
릴리스.
is
완전 릴리스. 더 릴리스. 얘가 하나 안 풀렸어. 조금 더. 오케이. 됐다. 오케이. Here. And then the release the. 오케이. 잠깐만. 노즈 컨트롤 살짝 뺄게.
Okay.
안 걸리게. 오케이. good.
Personally, I think as a disposition of the valve, I like it. The reason why a little bit deeper, but
Yeah,
after
right.
the hemodynamic or some
조금 빼고.
some
지금 패싱 끊었지?
anatomical
자,
the narrowing, we have to do the
이거 한번 이제
high
이거
pressure
비교하고.
once again.
Absolutely.
We need some the safety margin.
So, and usually, as you mentioned, is Professor Hwang, and slightly deeper, but this problem is the prior valve is too much narrow, and if you try to the eject position at the time of release and very forcefully is pull down the LV because of the very impacted space. So, okay, 이거 빼고 한번 시스 놓고 한번 재보자. 오케이, 자. 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3.
Great.
자, 이렇게
I think position-wise, I think it's almost perfect, right? Especially the reason why there are surgical valve here and the evolute device a little bit deeper. I think it doesn't, it doesn't matter in terms of, any permanent pacemaker, PVR, and also we can, if you get the upper part of the device, it is more, large, lumen for the coronary access, something like that, and so a little bit deeper, I think it would be more safe. Alan.
오케이. 자, take it
Just
back.
kidding. All right, it's a personal.
So, and is a recommended position just gold mark, slide the same level of the prior surgical valve level, or and the
Coronary
3 and
access
5 was yeah.
Coronary access would be okay.
Okay, we will check it out again. And first, and we measure the pressure gradient. There is some remain the pressure gradient, and we have put the 23 and the very small size. 그다음 밸브 요거는 바꾸기만 하면 돼. I'm gonna show pressure
I think
gradient.
for us, this is quite normal. Using or deploying self-expanding valve, especially for valve in a small valve. The beauty of it is that it doesn't expand the pores of the surgical
그치?
valve anymore.
Yes.
So choroid obstruction risk is not as high as when you push it out with the
Okay.
balloon expandable.
Okay, can you see the hemodynamics? Okay, flow hemodynamics, and as you can see the hemodynamics, there was slightly remain the pressure gradient, but it's much improved than before the TAVR procedure, and I think that is some acceptable point, and we removed that the pressure gradient, mean pressure gradient seems like approximately 17 or 18 difference, but in terms of a very high risk TAVR procedure, that could be, acceptable. If you remove that small pressure gradient, you're gonna do something. It's a valve fracture and additional high pressure. But this patient is main concern about the coronary the obstruction. The reason why we put the both coronary artery the protection system, and then we will check in the both coronary artery in the right를 먼저 한번. 자, 요게 라이트인가? 자, 이거 테스트 한번 할 수 있어요?
If you have a time, the rotational fluoroscopy and the
Okay.
transthoracic echocardiographic finding.
오케이, 한번 찍어보자, 라이트. 오케이, it's good. I think the space is good. And the left도 한번 찍어보자. 레디알로 했지? 요것도 연결돼 있지? 오케이. 연결 주십시오. 오케이, 준비됐어? 테스트? 오케이, 한번 찍어볼게요. 살짝 빼고. 자, 엔조. Yeah, there was some space, and out of the prior surgical valve, in the sinus space would be okay. So I removed the wire. 자, 빼고 여기 카스터 주고, and remove the left diagnostic coronary catheter, and then remove the right diagnostic catheter, and then finally check the coronary artery view. 오케이. 어디 있지? 라디알. 라디알 있구나. 자, 이거 뺄게. 잠깐만. 됐어. 그다음에 요거 이제 라이트도 뺄게요. 자, 오케이. 이거 보여주고. 자, 오케이. 줌하고. 알겠습니다. 이렇게 놓고. 자, 보자. 줌하고 지금 어디까지 나왔지? 페모랄로 들어가 있지 지금?
네.
잠깐만.
그래서 가운데 있어.
가운데 있지? 오케이. 오케이. And then the remove. And then 요 와이어 주고 LV 빼고 그다음에 파이널 한번 찍어보자. 자, 와이어. Okay, and then we will check the final aortogram. 자, 준비됐어요? 자, 테스트. 이게 이제 커스, 3커스 뷰지. 빼고. 오케이, 테스트. 오케이, 준비됐지? 자, 여기서 한번 찍어볼게요. 갑니다. 자, 펄샷. It's good. Yes, there is no AR. 그다음에 커셉 오브랩 뷰하고 저 레터럴 뷰에서 잘 펴졌는지 한번 봅시다. This coronary flow is okay. In the both branch is coronary flow is good. And this is 커셉 오브랩 뷰. 자, okay. And then the area 이쪽으로 잘 펴졌는지 레터럴 뷰. 여기서는 this is 앵파세 뷰. 앵파세 뷰. 오케이 됐다. 여기서 자 찍어볼게요.
Expansion is good.
Okay, cool. Okay, so I think there is no AR, and the previous view and previous view, cursive overlap view, is coronary space is okay. So slightly deeper the 전에 거. The position is slightly deeper, and the hemodynamics is, although there is a slightly remain the pressure gradient, that is quite acceptable. And this is one of example of the very complex and the valve in the valve case, and the low coronary height is VTC is very narrow, but its result is, I think, acceptable.
As
So
your
any
last
comment?
angiogram, Dr. Dogubak, anyway, we have to realize actually the surgical valve protected the device expansion to the coronary ostium, all right? Even in the low coronary height, actually the previous surgical valve a little bit protect in terms of compromise coronary ostium, something like that. And so we want to think about the very least, however, in the inside there are some it's good anyway, perfect case.
Congratulations.
Congratulations,
High,
right?
extremely complex lesion in the elderly patient.
Okay, thank you. Thank you.
Okay. Wei-Hsian, are you ready?
Hello.
Can you hear us?
Yeah.
I'm very proud of you and your team and in your hospital.
Thank you, Myeong-Ki.
Wei-Hsian, please introduce your patient cases and your team.
First of all, I would like to invite our team leader, Professor Wei, to say something.
Okay. It's an honor to be invited to join the SEOUL valve, and we're going to present the complex valve in valve, which is TAVR in TAVR. The case will be done by Dr. Wei-Hsian and Dr. Yung-Tsai. Yung-Tsai will present the case for you. Okay, thank you.
Thank you for your contribution. Thank you.
Yeah. And would you please show the case, Dr. Tsai?
All right.
There's a live case. It's a complex TAVR with the THV in THV. Then next. Actually, so. This old lady that got dyspnea on exertion, and he was admitted for the hospital, and she received the Evalu R 26 millimeter 6 years ago, and at the same time as right common iliac artery dissection was noted, so that the problem we do repair with a valve band over there. Next. Here we can show that the core valve was flared at NCC, and severe AR was noted because of a very severe symptom. The patient was decided to receive the THV in THV. The archive valve pressure gradient is 5/14. Next. Next. So we can see the previous index surgery that we can show here. The core valve implant quite high. Its mean height is around 3. The commissural alignment is good, and at a lot of time, the coronary artery, the lemon was 9, and the RCA is 15. Next. And here is today's multi-site CT show here. The inflow area, the area is 324, and the west over the previous annual sale area is 323, and the SOV was only 350, and the STJ high is the area over STJ is 360. VT-STJ at here is our right side is 2 millimeter, and the LCA is 0. And the VTC is to the left coronary artery is 1.9, and the RCA is 3.9. Next. So we simulation with SAPIEN 320, and you can see here that the RCA is relatively good for the SAPIEN 320, and LCA, I think that VTC is not changed, and the problem is VTSDJ. Next. The multi-site CT show the right internal iliac artery is repaired while we just insert the large sheath without difficulty. So that we do it from the right side. Next. And today we attempt to use the Edward sapien 3 20 millimeter plus 1, and the oversize around 0, and the main assay is from the right side, and the left cornea liberated with the unicorn modification and RCA doing the protection. And we also implant a protection device for this patient. Next. Next. So today's object is THV in THV. Well, our consideration is VTC and the VTSTJ. And also we founded the first THVA size position, and the commission is alignment is quite important for this case. The procedural position for the second device is also a very important thing. And the protection coronary artery device is limited modification and the coronary protection. And the other issue is do we need to very high implant in every time procedure? I think that later we will talk about the first time THV position. About today's case, is there any problem for this case?
I would like to summarize. This patient have a failed self-expanding valve, which was implanted at the implantation test of 3. During the first implantation, there will be no issue for coronary because the left coronary high was around 8 to 10, and the right is even higher. But the second time, THV, there will be an issue because the near skirt height, we have measured that it must be over the coronary takeoff. So if we implant the second valve, it will lead to coronary obstruction on the left coronary because of the near skirt. So this time we would like to do lifting modification. If it fails, we will do coronary chimney stenting on the left side. However, for the right coronary, the VTC is still 3 point something. So we think that the right coronary is still okay. So we will do protection. If nothing happens, we just remove the whole system. Regarding the sizing of the second valve, we have experienced that we should use a CT measurement before the procedure to choose the appropriate size of the second valve. In this patient, although the first valve was 26, however, if we measure the waist and the annular level of the second of the inner diameter, it shows it was 20 something only. So we decided to choose a 20 millimeter SAPIEN 3 over field, maybe 1 to 1.5 cc instead of 23 under field, because we think that oversized underfeeding will lead to pinwheeling, and that may compromise the hemodynamics and the valve performance. The third thing is that the implantation depth of the second valve. This patient, if we implant the SAPIEN 3, keep the inner skirt of the SAPIEN 3 20 millimeter below the coronary takeoff of left side. After lifting modification of chimney stenting, then it may result in at the same level of the coronary takeoff. So that means we should aim at inflow portion of the first valve as the landmark or the marker to implant the second one. That can keep the inner skirt of the second valve below the coronary takeoff. That's our strategy. This is the current strategy of doing transcatheter heart valve in transcatheter heart valve in our center, because we think that every patient have a different first valve implantation. So the valve position is different from case to case. So we respect the native anatomy of the patient. That means that we aim at the native coronary artery as the landmark for the placement of the second valve. That may make things easier. That's our strategy. Do you have any question or comment?
Really appreciate your educational cases. Any comment from the panel?
Actually, this case is what we're going to occur more and more, I think, because in the first case, the evolute was very shallow implanted. So when doing TAVI in shallow like this case, it can cause a very difficulty in the second TAVI. So I think we are doing shallow in evolute, but now if we're doing young age TAVI patients, maybe about 4 millimeter deeper can cause the neoscleral plane below the coronary plane, then we don't have to need a basilica or unicorn like that. And I have a question to Dr. Wei-Hsian. So I think DW Park's case was valve in valve, not TAVI in TAVI, but DW Park's case can be done in leaflet modification and LCC and RCA protection. So in this case, I think coronary protection will not be good. I think leaflet modification will be the right case. But have you ever done leaflet modification in RCC or LCC same simultaneously, or have you tried only LCC leaflet modification?
Yeah, we would like to do left side because the right side is still, I think the distance of 3 point something is still okay. Because we implant the 20 instead of a 23. If we implant the 23, that would be an issue because the 23 will cause valve expansion of the first SEV. But we use 20, that should be okay for the right, but not for the left. The left is always an issue.
So what are you doing now? Wei-Hsian, what are you doing now? Please explain. Tell us the
sound transmission is not good.
Okay. On a fluoroscopic finding, please tell us what are you doing now?
Pardon?
What are you doing now?
Now we are trying to do high-wire traversal of the left coronary cusp. We use a multi-purpose guide to direct to the LCC. And we use a modified tip, the pigtail, to direct the direction to the ascending limb of the left coronary cusp. In that way, we can guarantee the puncture site is on the left coronary cusp. That's what we are doing.
Okay.
Well, I wonder, all the expert, when you do leaflet modification, what will you do?
Actually, we are continuously see what you do and try to learn your procedure.
我们听不到嘞。
Tell us your procedure continues. This is the injection for the left coronary artery.
我们听不到。
That was the arteries.
好。他们能不能听到我们？ Okay, if you can hear me, I cannot hear you. But if you can hear me, we are now doing the leaflet traversal with the Astato wire. As you can see, it was successfully pierced by the Astato wire. Before doing that, you must choose a projection that can show the left coronary cusp where, and then we in this patient because the evolute system is have a narrow waist, So you have to choose a guide to direct to the LCC. But in that case, the direction or coaxiality is not favorable for leaflet modification or for the traverse of the starter wire. So you need a secondary curve, which is provided by a modified pigtail. As you can see, a modified pigtail can direct to the ascending limb of the left coronary cusp, and that can make things easier.
One more time.
Oh, we lost the wire. We'll do it again.
How do we confirm that the cannulation is correctly done in the left correct valve cusp?
现在是在里面吗？好。The choice between unicorn and basilica, as mentioned before, is depend on which the leaflet to be modified on one side or on both sides. In this particular case, we would like to modify the left side and protect the right side. We believe that with a 20 millimeter Sapien 3, it can well expanded without significant compromise of the right coronary cusp, right coronary artery. So we chose to do unicorn in this particular case. But if the patient have a risky procedure for both coronary artery, basilica is on both sides a better option. Or even use the shortcut device. I just wonder who of you have the experience on shortcut, and maybe you can give some comment on this.
Is that a manual puncture or did he electrify the?
Electrify.
Can't see anything on the TEE.
Is there any experience from the audience? Please explain. I'd like to learn how to the procedure. Use the.
Dr. Wei-Hsian, can you hear us?
今天这个转播好奇怪，你们慢慢做没关系，反正已经没事了。
So I think what they're trying to do now is they pass the starter wire over, and what they're going to do is most probably going to bring a microcatheter across, and then gradually trying to.
什么时候做 right side protection?
Yeah, and then subsequently they're going to further dilate the fenestration that they've created serially. That's how they're going to do.
我们要不要先把 right side protect 好？
How do we know that the wire the direction is correct? How do we realize that?
So I think the most important part is here on the TEE, it's showing quite well that it's now targeting the right leaflet. It's traversing right at the base of the leaflet and in the LCC from the TEE here, as we could see. And, actually, you can see it quite well there, actually. Yeah. And now the most important part is for the imaging part, the most optimal part is to really show the whole LV cavity, making sure the wire does not entangle into any parts of the mitral valve apparatus and etc. So I think they're probably mostly now focusing on how to treat the balloon dilatation of the fenestration now.
Now they are doing the balloon dilation.
Yes. So they're going to, the unicorn step, usually from our center's initial experience, we first further dilated with a coronary balloon around. Some use 3 mm, some use 4 mm, but irrespectively, it will be a coronary balloon, and then subsequently going to be a peripheral balloon of around 10 millimeters, and then within it will deploy the SAPIEN valve. That's how it's usually done.
对。你现在做protection。
So we can confirm the site of leaflet left leaflet penetration by TE. We can see the wire passage around 1 o'clock. And the second, there are two ways of basilica laceration through electrocoagulation. But he tried to use another way, just balloon passage through the penetrating wire and balloon and rupture the left leaflet. Then implant TAVR. I'm concerned about the hemodynamic instability immediately after balloon-mediated rupture of left aortic leaflet. Is there any problem?
We have made inflation.
Can you hear me? Dr. Kim, please use the mic. You mean in the short axis view, in the transesophageal, and then we can confirm the correct cannulation. You mean in the 1 o'clock in the short axis view? Oh, okay.
Just to supplement for the imaging part, so from our center's experience nowadays, we now use 3D MPR reconstruction sometimes, confirming that it's really at the cusp, passing through the leaflet and making sure that it really goes in a very good track.
We have made a small balloon dilatation, and now we are trying to do a stiffer wire through the punctured hole.
시간이 얼마 없는데 어떡하지? 얘기 좀 해줘. 5분 남았어.
How do we realize that the unicorn procedure was successfully done or not? Or how do we evaluate that the efficacy? TE.
So, I think one of the important parts, just trying to bring up, because everyone is talking about leaflet modification nowadays, we need to know what really leaflet modification is about and the different types of modalities. Basilica here causes a laceration as a tear, and it causes a very clean cut. That's what's really happening. But in unicorn, it's slightly different. And the most important part is unicorn, the initial design by our team was to gradually create a small fenestration within the leaflet, gradually making it large enough to pass through the SAPIEN without destroying the leaflet before the deployment of the valve. And within that hole, we will slowly deploy the SAPIEN valve. And then at the moment of deployment, it will cause the laceration of the leaflet. That prevents a very smooth way of ensuring that the leaflets will not obstruct any part and making sure that the leaflet is being lacerated in a very controlled manner. As mentioned and as asked earlier, how it could be confirmed is usually using the coronary, after the coronary balloon, the AR is not that evident because the hole is probably is still being obstructed by the wire itself. But after using a peripheral balloon, around an 8 to 10 mm balloon, after dilating it, it will cause a large enough hole, causing an AR. And on the TE, and making sure on fluoroscopy, if you see the wire motion is not going into the center, then you really ensure that the wire is within the fenestration instead of really tearing the leaflet before the deployment. So that's how we really assess it.
Push balloon.
I have a question, okay? So how many the sizes of the final balloon? And because there's the diameter of the SAPIEN is 14 Frenches, yeah.
So usually the recommended balloon size is 10 millimeters, at least 10 millimeters. Too big, you may cause an over-laceration. Some centers use a modified version around 12 to 14 millimeters. Sometimes that may cause pre-deployment leaflet laceration. So around 10 to 12 millimeters is the optimal size usually.
What is the current stage in the fluoroscopic image?
So what they've done just now, I think now they're passing on a microcatheter into the LV, and they're probably going to exchange a stiffer wire, so that subsequently either they can further perform dilatation of the fenestration using a larger peripheral balloon, and then later on they can deliver the sapien valve across the fenestration and then deploy it within. So the most important part for unicorn is we do not lacerate the leaflet prior to the valve deployment, because once you've lacerated the leaflet using a balloon before the deployment, the leaflets will really be flying around and you will not be able to predict where the leaflet goes. With the leaflet integrity remaining intact prior to the deployment, that's how you really control release and lacerate the leaflet. That's the purpose.
不是，我们现在怎么办？
现在就等对方处理问题，因为看起来我这个套都没有任何的问题。
那我的声音会传到会场哎。
그래서 여기를 좀 해야 될 것 같은데. 5 minutes.
Wei-Hsian, can you hear us?
就开扩音了，手机开扩音。
Can you hear us? Actually, Dr. In's show us are very educational and some rare and complicated cases. So I'd like to learn how to do it.
We have a safari. Now we use a balloon caster to exchange wire to safari wire. 可以。It's good. It's good. Okay.
And then they will do the dilation with a peripheral balloon, right? Correct?
看得到，听不到谁？他们应该看得懂。对，抓住了，好。我们要先 protect right side。拿掉，马上拿掉。我们要 protect right side 了吧
？Hello. Well, I come from another center from Hong Kong. Yesterday, I remember that we did a case. It's not a valve-in-valve case. It's a native aortic stenosis of very heavily calcified.
And then we make a big balloon inflation, and then finally we implant the valve.
Okay. Very heavily calcified leaflet. We want to do some leaflet modification and then similar procedures, but instead of dilating with a peripheral balloon, because the valve is extremely heavily calcified, we use a peripheral shortwave balloon, all right, 10 millimeter shortwave balloon, and then do a couple of leaflet modification, hoping to break the calcium, and it turned out to be the result is quite satisfactory. So instead of using a peripheral balloon, sometimes you can use a peripheral shockwave, all right, in order to modify the calcium. There's some modifications of this sort of unicorn techniques.
让我帮忙。I see.
디바이스라는 걸 보고 그냥 끝냈으면 좋겠다. 디바이스라는 거 뭐지? 아까 사피엔 한다.
재밌는데 다른 사람들도 이런 케이스 못 봤으니까 그냥 사피엔 하는 거 훨씬
스나로 잡아서 당기는 게 없으니까 보통.
你去洗好了。
이거 하려면.
别动。
셀프는 이게 약하니까 이게 잘 찍지 못해요. 물론 밴드를 하는 거 하더라고요.
它有一点靠左边 anomalous.
Actually, this session will be closed and the 4:30, but this is the last session and the live demonstration and the TW's lecture. But
A little bit
personally,
anomalous,
I'd like
right,
to
Corey?
enjoy
So
the last
we use fishing
demonstration.
technique.
We have a time, so we observe what's going on continuous. I'd like to learn something new.
They're going to chimney the right coronary. Protect right coronary.
Because there is no communication, please explain the procedure in the somebody's for the audience right now.
So I think they're because they're also protecting the right side now as well. So they're trying to engage, protect the right side before really doing the further deployment and before further balloon dilatation of the fenestration. They're going to make sure the right side is protected as well first.
Okay.
Okay. We are now protect the right coronary. It's the wrong way. Because the engagement is not so good because of anomalous opening of the takeoff of the right coronary. So we use a fishing technique. Use Seung blue wire.
On the screen, the operator is changing. Yung-Tsai is at the behind and the. That's correct.
I think for the basilica procedures, if you lacerate the valve, then usually these sort of patients may have very severe degree of aortic regurgitation, something like QAR, and then hemodynamically they will deteriorate. But you can see in this sort of procedure, Unicorn, as my colleagues have mentioned, very controlled dilatations, and then you can see that the patient is hemodynamically quite stable, all right? Even from the TEE, if you monitor it closely, usually the degree of AR may not be that severe.
Anomalous. Good. Wow. All right, we have already get in the right coronary. Deeper, I think. Deeper. Side branch. Side branch. Okay. Main trunk. All right. 40. Guide extension. Guide extension, Godzilla. In doing coronary protection, we strongly recommend to use extension caster. The caster is softer and it can conform to the local anatomy. And sure. Thank you.
We will change the lecture first and then return to the live cases. Okay. The lecture, yes. Lecture is the upcoming major issue, the all BBI, TAVR in TAVR, and the TAVR in the SAVR. TW, please.
Okay, thank you. So, and this is some summary about the valve-in-valve procedure and in the interventional aspect, what we concern about the valve-in-valve procedure. This is my disclosure. And this slide already shown in the Professor Allen Young, and the overall valve-in-valve procedure is going up. Among the valve-in-valve procedure, and compared to TAVR in SAVR, and the TAVR in TAVR is very rapidly is going up, and might be later than 10 years later, more than 10% would be TAVR in TAVR procedure. And practically, and the reduced TAVR is a feasible procedure. There was a practical question, and this data is a very big data, real-world data based on TVT registry and the Rajimakar and the SDS TVT registry compare overall 1,020 reduced TAVR, and the second valve was using sapien valve, and they compared 349,000 native TAVR valve, and there was this published Lancet journal provided the reduced TAVR is clinically feasible. And looking at the overall major outcome, death, stroke, any readmission, and the death or later reduced TAVR, and the overall outcome is quite comparable regardless the TAVR procedure is reduced TAVR or native TAVR, and the real-world data shows the reduced TAVR in terms of clinical outcome is quite acceptable. So we are consider two scenario, and TAVR in SAVR and the TAVR in TAVR, and our live case shows the TAVR in SAVR and another complex case in the TAVR in TAVR, and compared to the TAVR in SAVR, and the second TAVR in TAVR is much complex, coronary obstruction risk much higher. Also, and the TAVR explant is much associated high risk, and the reduced TAVR and the TAVR in TAVR is more complicated than TAVR in SAVR procedure. And on the basis of the CT scanning, and we think about a lot of point about the nail cut height or leaflet overhanging and the valve expansion, and the reason why about the durability and coronary obstruction risk, several anatomical things we should consider. So, and the procedural planning is we are very familiar with nomenclature, neo-scutal plane, what is coronary risk plane, and which is the VTA and the specific risk of reduced TAVR we consider, and also very device specific combination, short in short and short in long, long in short. Also device sizing, and absolutely mainly based on CT scanning, and just except short in short, and it can be a bit complicated, and we have now available planning tool is app or simulation, and this is a common combination. Our live the short in short, short in tall, tall in tall, and tall in tall, and there is a different combination. Is a combination specific planning is required, and usually, and the second valve is a short. Is the regardless, and the first valve is the short, and the second valve is a short, and the tall is it doesn't matter. But the first valve is a tall, and the second valve is a short. Could be comparable, but is tall and tall is quite complicated. Usually don't do, and the tall in tall the procedure just except a very emergency case, and the reason why coronary risk is much higher in the this is the largest Spanish registry. Native valve case, coronary obstruction quite low, less than 1%, but valve in valve TAVR procedure is a 5.7%. Is very high. Also, rescue therapy, 80% success, 20% failure. Coronary obstruction associated high risk of mortality. That was absolutely catastrophic the risk. So, and the key to handle coronary obstruction, valve in valve TAVR procedure, prevention is first, and one ounce of prevention is worth of a pound of cure, and is a much important prevention. And we know some terminology, neo-scutal plane and coronary risk plane. This is some assess of the coronary obstruction risk. What is the neo-scutal plane and coronary risk plane? And this diagram shows the neo-scutal plane. And if you put the second valve in the upper part is usually and the neo-scutal plane, and it put the second valve according to the outflow of the second valve, neo-scutal plane was decided. And also CRP with terms coronary risk plane, and this is the lower part of coronary, right coronary artery, coronary risk plane over here, left coronary artery, coronary risk plane over here, and according to the combination, neoscutal plane and the coronary risk plane is coronary obstruction risk absolutely differ. And the left case, neoscutal valve plane covered right coronary as well as left coronary. There was a risk of post coronary obstruction in the right panel, and the neoscutal plane is below right coronary artery, left coronary artery. Obstruction risk is quite low, and as angiography, we can measure the where neoscutal plane is upper part of the valve, and the coronary risk plane is the low part of the coronary risk. Also, we consider some space. So this is demonstrated the neoscutal plane and the coronary risk plane, some combination, and the calcium Cheng about this plane we are consider coronary risk. So, sorry. Okay. Okay, and. Okay, and so also in valve procedure, first valve was absolute valve, second valve is the SAVR valve. We are matched some node, and depending on the neoscutal plane, the plane was decided, and also we are according to the depth, so we consider risk of coronary obstruction as well as we put the too much differ and the leaflet overhanging could be hemodynamically matter. Also, as shown in our first live case, VTC, virtual and the aorta distance is so important. More than 4, it is okay. In our live case, seems like 2.3, and there is a very some space zone. And this, although we consider coronary obstruction, that case is okay. So VTC, although the valve frame is covered coronary ostium, there is a sufficient VTA. Coronary risk zone is wide, it doesn't matter, but it's a very narrow case. We consider another things, and the leaflet modification, coronary protection as shown in our case, and the very narrow VTC and also valve frame totally cover coronary ostium, we should consider surgery. And this is a VTA zone comparing the coronary risk plane and the stent frame, and this is quite comparable. And at least we make sure more than 4 millimeter coronary risk zone. That is so important. And this like second valve is tall valve. It usually doesn't matter. And it's a very narrow space, wide space. And in the short case, according to second valve position and space with we should consider, and that is also, as shown in our live case, stent frame view. The frame alignment view is very important at the time of deployment. At this view, we measured the neoscut plane and the coronary risk plane. So, and during the valve-in-valve procedure compared to the native valve procedure, very complex, sometimes confusing, sometimes the expert is, our experience is limited and the need simulation, and we can, a lot of things to do, and planning, case selection, and procedure is sometimes very complex. Very luckily, valve-in-valve procedure web is available in the smartphone, and most cases we use radio TAVR in the valve-in-valve web in the binibapar is focused on a lot of very practical case, and some complex, but if you use the valve-in-valve web, and you can assess overall risk, radio TAVR coronary risk, and high risk or low risk and intermediate risk. This is practically is very, very helpful. Also, and so nowadays some simulation tool is available, but not yet available in our cath lab, in some center in Japan, in some center in the European country. And this tool was useful if you put the second valve, overall coronary obstruction risk, and the simulation that sometimes quite helpful assess the coronary risk zone and how much difference. So, and this is virtual simulation, is TASI program, is sometimes helpful considering in valve procedure. So, and sometimes very the highest, extremely high risk of coronary obstruction risk, we are consider active strategy for protection, and is just very passive protection is coronary protection, put the wire, put the stent, but there some case too much extremely high risk at the time, we consider very active the management for coronary risk. This is some typical case of the Basilica case, and the Basilica case reported in the JAG intervention. Overall success rate is very high, but in the practically, and we never consider in our real case, our simulation case, it seems like very complex. In the real world, overall adaptation is Basilica is not quite often. And as you mentioned, is outlined in the shortcut is available in the U.S. There was a P Cardia company, Israel company, is very the prior failed surgical valve in valve, and that can be applied to cut the prior the valve leaflet. But it's a problem. It seems like very straightforward, but the problem is overall cost too much expensive, $16,000. There is not much cost than the SAVR itself, and in the economic problem, the burden is not easy. So in summary, and as shown in the live case demo, and the reduced TAVR has presented a new technical demand, and in the near future, overall proportion of reduced TAVR is going up, and the systemic approach using in vivo CT data is absolutely crucial. The planning is so important to minimize the risk of serious complication like coronary obstruction, coronary root injury, and the sinus sequestration, and severe PPM. And the simple standards approach using neo-scutal plane and coronary risk plane and the coronary risk zone is guide procedural planning and support consistent decision making. And the new imaging-based tool like reduced TAVR app and the simulation could be helpful to simplify and optimize the planning and mitigate the TAVR in TAVR complication. Thank you for your attention.
Any comment, question? Okay, good job. We will move the, okay. Oh, wow. Wei-Hsian, can you hear us?
Hi.
Yes.
Hi. We just implant the valve.
Okay.
Facing off. Okay, we show the procedure to you.
Yes, but there is a long time is not to communicate with you, and please explain the previous the technique, step by step.
Okay. Let's see the final step to determine whether we should stand the right coronary or not. Now we are， 你们要先，不是，要等你们弄完还是要 Okay, please play back. Yeah.
Yes.
We use a multi-purpose guiding. AL1, sorry. AL1 guiding to direct to the left coronary cusp. And as you can see, we use another modified tipped pigtail to direct to the ascending limb of the leaflet. In that way, we can confirm by angel that we are direct against the leaflet. So
how do we confirm that the wire was passed to the left?
Yeah, this angel, you see, this angel, you can see the pigtail is direct to the LCC. And also, we confirm that by T. Can you show the T?
Yes.
It's the previous one, yeah.
You know,
the is when we do the procedure TET.
Yeah, you see, the caster is inside the left
Right.
coronary cusp. Dr. Liu, could you please explain that?
Okay, keep going.
Anyway, after confirmation of the position of the caster, you can do leaflet traversal. Dr. Liu, would you please explain the T?
Can everyone hear me?
Yes.
Okay. So we use the long axis view and use the X-plane technique. And you can see that we isolated this valve L cusp, and we identify the catheter in the left cusp. And after they puncture through, we also found the wire is shown at LVOT.
Can you see that?
Yes. Yes.
Yeah. After confirmation of the leaflet traversal, then we can do a small balloon dilatation. 4 millimeter balloon. And then
Peripheral balloon.
we use peripheral balloon over the wire balloon to track the the balloon in the safari wire, to give the safari wire inside the LV. After that, we do right coronary protection, because if you use a larger balloon dilate the left side, the hemodynamic will unstable. Will be unstable. So we protect the coronary first, and then we do balloon dilatation with a bigger balloon. This one.
12.
This is a 12 balloon. You see, the waist is coming up. And after that, the T can show severe aortic regurgitation and the blood pressure dropped to 90 systolic. And then we put in the valve immediately. And we already measured that we will aim at align with the upper edge of the coin takeoff. Because we already split the leaflet. So at this position, the upper crown or upper row of the cell is opened. So it won't cause any flow compromisation. So as you can see, usually we don't count the nodes. We just respect the native anatomy. We select the coronary takeoff and the interrelationship between the new valve and the coronary. Because everything is moving, and in every case, the first valve position is different from case to case. So we choose the anatomy that is stable and won't move during the valve implantation, and that's the coronary. So aligned with coronary, we can easily deploy the valve. And as you can see, both sides, coronary was patent.
Excellent.
And it seems that we don't need to stent the right coronary. And that's the whole thing.
Excellent. Beautiful.
Thank you.
Any comment?
Any comment?
stent 你要出好 ，stent 会卡在中间，所以
用那个去收，用 guideliner 去收。
guideliner 键。
Dr. Yin, can you hear?
Yeah. Yeah, Dr. Kim.
Yeah, wonderful demonstration.
Thank you.
Previously, I asked the question, the hemodynamic instability immediately after balloon-guided tear of leaflet. So you also mentioned there is a severe regurgitation and hemodynamic compromise, thus you hurried up the implantation of SAPIEN. Compared with traditional basilica with laceration, you chose this unicorn procedure because it is more simple.
Yes.
In your experience, how is the kind of problematic of such kind of transient hemodynamic compromise immediate after leaflet tear with balloon?
Actually, it depends on the mechanism of valve failure. This patient has a mechanism of regurgitation causing the valve failure. So the patient already tolerated the AR for a long period of time. So in this kind of patient, we can safely dilate with a larger balloon and put the valve in without much difficulty. The systolic blood pressure is usually 90. Before the procedure, it was 130. So it's still acceptable. So as you can see, all hands on deck. Our implanter, 4 implanters are all in the room. So we can do the procedure very fast.
Okay. Thus, in case without any significant regurgitation, you usually choose a traditional basilica procedure?
It doesn't mean that we won't do this. It still can be done. It still can be done. Basilica can also cause severe regurgitation. So I think unless you don't do leaflet modification, otherwise this is an issue. So you have to have the device, I mean the transcatheter valve, prepared in advance, and at the bottom of the table, and everything is ready, and then you do the large balloon dilatation, and then put in all the things. With a basilica, you make the final laceration after you have already prepared everything. Then you do that.
Can we step?
As you can see, now we show you the hemodynamic. There has been no gradient. Even we use 20 plus 1 cc, Sapien 3. There has been no gradient between the LV and the ascending aorta.
Excellent. I'd like to thanks for the very special and educational cases and your team, Yung-Tsai, and it must be a Dr. Tsai, right? Correct?
Dr. Cao, Dr. Lee, and me.
Yes, you suddenly appear. Okay. Anyhow, it's a very nice demonstration, and really appreciate the greatest contribution in the SEOUL valve live cases. Any comment? Any comment?
Actually, Dr. Lin, I have a question for you.
Yes.
So unicorn procedure is usually done by balloon expandable valve, right? So
yeah.
I've seen some case reports of doing unicorn in self-expandable valve. Do you have any experiences in self-expandable valve?
Yeah, we have 2 or 3 cases I can remember. But as you mentioned, in self-expanding, because the valve deployment takes time. So after you close the valve, you must rapidly deploy the valve at the first attempt. With experienced operator, this can be done easily within seconds. So after that, the patient's new valve has functioned, and the patient can be stabilized. If you were not satisfied with the position, you can retrieve after the patient stabilized and do the implantation again. That's the key. So self-expanding still can be done.
Okay, it's time to close this session. Thanks again, Dr. Lin, and thank you. See you soon in the surprise. Thank you.
Thank you, thank you. Thank you, everyone.